Now we come to our last talk before we have our photo shooting and then go to lunch. But first, the photo shooting. That will be Heinz, and he'll talk about the ryanodine receptor in German. And this is a real challenge for Heinz because he's been in London for 21 years, and this is his first scientific presentation in German since the time when he wrote his doctor's thesis in 1900-something. Well, thanks for the invitation. Indeed, my last German presentation was held in 1995 in Regensburg, so I'm rather nervous now. In case you'll hear some unusual grammatical designs in my presentation, I would like to... Good. After this short interruption, this is the Children's Hospital in London where I'm working together with my colleague Francesco Montoni, who unfortunately isn't able to be here. Today we take care of one of the largest groups of children with congenital myopathies in Europe. And right in the beginning, we received a little overview today of the various congenital myopathies that there are. And this is a concept which in the 1950s and 60s developed when new techniques of examining muscle tissue were introduced. And it was thought in the beginning that those children who present at birth or in early infancy with muscle weaknesses, we've seen that there are very many differences on the level of muscle biopsies. And one of the genes, which meanwhile has been found out to be one of the most frequent causes of congenital myopathies, is the RIR1, the ryanodine receptor gene. And here you see data from our English cohort, and we see mutations in this gene in about 2/3 of our patients. Now, what is this gene doing? We saw a video beforehand. Now I'd like to show you another one, if I can find it and it works. Doesn't look like it. Okay, doesn't seem to work. So this gene, or this protein, is playing a very important role in this excitation-contraction coupling process. This is the process where an electric nerve impulse is transduced into a muscle contraction. And one of the most important elements in this process is calcium, and calcium is released by the ryanodine receptor. In this excitation contraction coupling, two important receptors are involved. One is dihydropyridine and the HPR receptor, and they actually work like an electric switch. If the muscular cell is exposed to an electrical impulse, the receptor is changing its structure, and based on that change of structure, a secondary structural change of the ryanodine receptor is induced, and the ryanodine receptor is then releasing calcium out of the storages in the extraplasmatic reticulum, and based on that release, the muscle contraction takes place. In the past 20 years, it has been found out that any mistakes or mutations or changes of that gene are among the most frequent causes for congenital neuromuscular diseases. And the first disease that was linked to it was the central core disease. And I'll give you an example. This disease will be inherited dominantly from one parent to children. In recent times, we have seen that there's a large other group of diseases which also trace back to mistakes in that gene, faults in that gene. One of them is central nuclear myopathy. The other two are multi-mini-core disease and congenital fiber disproportion. This is causing a caliber change in the muscle fibers. And I would just like to mention that these diseases are not totally different. There are quite a lot of overlaps, in particular when you look at the muscle biopsies. And if you or your child suffers from a centronuclear myopathy with a ryanodine receptor mutation, then you'll find more similarities with patients with multi-mini-core disease or congenital fiber disproportion. And I think that's very important for the prognosis and also in view of the development of new treatments or therapies. There's just one more disease which is also caused by ryanodine gene. This is malign hypothermia, but I don't want to talk about that. But this is a very difficult difficulty in anesthesia. It's really a malign fever, so to speak, and this can be a response to certain, or can restrict or impair the response to certain anesthesics. So what exactly is happening in these diseases? In a very simplified form here, usually if there's an electrical impulse going to a muscle fiber, you'll have the normal release of calcium based on which the muscle is contracting. Now, if you've got a change in the gene which causes malign hypothermia, you will have a massive release of calcium. So you've got an increase of the contraction of muscle, which leads to a collapse. In centronuclear myopathy, based on mistakes of this gene, there's not enough calcium being released. And in that case, there are two explanations. One is that the receptor is leaking and is losing calcium between muscle contractions, and this is why it can't release enough calcium during a contraction. And the other possibility is that this receptor isn't communicating with the DHPR receptor that I just mentioned, and this is why there is no transduction of the electrical impulse or transmission of the electrical impulse. Just as an example, how various changes in the genes can have an effect. On the left side, you see a small boy with centronuclear myopathy based on recessive mutations in the ryanodine receptor gene. On the right side, you see a young man with a mutation that leads to malign hypothermia. And I think the difference in the muscle structure are very impressive and remarkable. Now, before I talk about centronuclear and related associated myopathies, I would like to talk about central core disease, which is a dominantly inherited disease. It was called central core disease because on muscle biopsies you see these kind of circles that look like they are punched out. So it doesn't mean that there are any holes in the muscle tissue, but certain elements of the muscle fiber aren't present. And this is usually a very mild form of a disease, and usually it leads to a weakness of the muscles around the femur. And very often the parents have the disease as well. But it was never diagnosed before they had children, or they had never had any medical examination because this disease is very variable. Sometimes the symptoms are very mild. And I just wanted to briefly show you, because this is a very important diagnostic tool, also for this disease, but also for other diseases. And it's not that all muscular diseases affect the muscle in the same severe way. Some diseases like the multi-core disease can actually have a very reproducible pattern. If you look at this MRI imagery, then you will see that, I hope it works, that here you have a muscle which is white, almost like fat. This is very much a muscle which has been changed by the disease. And then you've got a dark muscle, which is a normal muscle. It's not just important for diagnostic reasons, it's also important for practical reasons to know that, because many of the patients are very mobile and they have a very long walking distance, because the muscles which are still there, which are still working properly, can really compensate a lot. And that's important in case of centronuclear and other kinds of such diseases. The central core disease is very much associated with changes in the ryanodine receptor gene, which are focusing on one certain area. And this is the reason why this disease was described even 20 years ago, whilst the centronuclear and associated diseases have been described only recently, because the gene is rather big and it's very difficult to analyze. Now, the other disease, which also is connected to ryanodine, is the disease called multiminicore disease. And it causes similar changes in the muscle fiber, but they're not so very much defined. What's very typical for this disease is that the patients are very much, in those patients, the eyes are usually affected very much, and that's very typical, and that's something they have in common with other genetic forms of centronuclear myopathy. Well, we had one patient who had quite a lot of similarities with the multiminicore disease patients, but she also had these central nuclei, and for that reason we thought of a centronuclear myopathy, and that was the beginning of a more systematic approach to examine other patients with centronuclear myopathy. And indeed we found out that the recessive ryanodine mutation is playing a very prominent role in this kind of disease. This seems to vary from region to region. There are many children who are described in this article that came from South Africa. So obviously there seems to be a cluster there of centronuclear myopathies in South Africa. One observation I'd like to highlight, which I think is very important for clinical trials, is that compared to other forms of centronuclear myopathies, some of these children have shown a very good development, not as much delayed as in other forms of centronuclear myopathies. And I think that's important when you want to assess certain therapy outcomes or successes. What I also would like to mention, and I think I said it before, is that this change, this alteration in the gene is very much spread through the whole gene. And so you have to analyze the whole gene if you want to find the mutation. And you cannot just focus on the same areas that you would look at when you look at central core disease. Now, the mechanism in the centronuclear myopathy and in other recessively inherited myopathies is not as well understood as the mechanism of the central core disease. But what seems to be a very important mechanism is that the two receptors that I just mentioned, the dihydropyridine receptor and the ryanodine receptor, are not associated in a way that they usually would be, and that for that reason the transmission of the electrical impulse is preventing the calcium release, and that's a different mechanism than in case of the central core disease. Now, just briefly, let me mention two articles that are also very relevant with regard to the underlying pathogenic mechanisms. One comes from Dowlin, describing that many patients seem to have a problem with the muscle oxidation in the muscle fibers, and that many patients or animal models of this myopathy also respond to antioxidants. And we've also, with the support of the Myotubular Trust, were able to conduct a study which seems to indicate that next to the calcium release, other metabolism pathways which regulate the muscle could also be detected, which can be targeted by therapies. Now, in the end, I'd like to give you an overview on the various therapeutic approaches in the ryanodine-associated myopathies, and I have to underline that many of these drugs that I mention here were not relevant directly for centronuclear myopathy, which would be dantrolene, which I put at the top of my list. This is a product which reduces an excess of calcium release, and for that reason it's probably only relevant in case of mutations in which an excessive release of calcium takes place. It's quite similar for the group of the Rykol's medication. They stabilize the calcium ion channels with a leakage, which is probably not true for all centronuclear mutations. Antioxidants, I mentioned them, I think. Clinical trials that are currently ongoing. Other drugs like salbutamol or the mesimol, which Jim Darling mentioned, are only described in small cases, but they haven't been studied systematically. Genetic manipulations like allele silencing, meaning that you just knock out one copy of the gene, they are more relevant for dominant forms of the disease, not for recessive ones like the centronuclear myopathy.
To sum up, mutations are one of the key reasons for MTM diseases, especially regarding the RYR1 receptor. Usually the results are a bit more mild than that of CMR, but there are similar developments. I think one of the key points, or even two key points, are that other proteins, what we've just heard, other proteins are involved as well. And we have heard that they interact in a certain way, and that therapies concerning one of them can be relevant to other proteins as well. In this group, the mechanism seems to be different, and there may be other approaches necessary. I think the second key point is that with this gene in particular, we should think about what conclusions onto the calcium canal are had by the therapy. I would like to also thank the Myotubular Trust and a very, very long list of collaborators sitting both in London or in other places in the UK. I probably forgot some colleagues. Thank you very much for your attention, and I look forward to your questions. Thank you, Heinz. Who has questions concerning the ryanodine receptor? I'm sorry, I looked in the other way. That's not very kind of me. Hello, our son was diagnosed with central core disease. You said that it was dominant, but my husband and I do not carry this genetic defect. Well, this actually happens on occasion, not very often, but it is a very large gene and it has a tendency to mutate spontaneously. That means that we have a significant number of families who have this problem, and where all of a sudden this issue occurs. I have about 4 or 5 patients where this takes place. So that doesn't mean that the diagnosis is wrong. No, it doesn't mean that at all. Mostly there are dominant mutations, but there are also de novo dominant mutations. Simply, the larger the gene, the more mutations can take place de novo. Just to sum up, what I've talked about earlier, everybody of us has some mutations in the DNA, and in every generation there are new mistakes, faults in the DNA. So from parents to sons and daughters, there can be 3 to 4 new mutations. I have another question. A friend of mine also has CCT. Her parents, her sister and her brother, her parents and her sister are not concerned, but her brother also has it. Well, I should have gone into more detail there. The CCD is dominant in about 80 to 90% of the time. But there is also a small group of patients where the CCD follows a recessive way. We have had the diagram with the Simpson families in the beginning, where every parent has one copy of the gene with a mutation, and when both come together, then the disease can form. It is also a question of how the medical specialists, the pathologists, look at the muscles. Some histopathologists will say that probably a softer way of therapy is in order.
Hallo.
Hello.
Also mein Sohn hat auch CCD.
My son also has CCD.
Momentan so, dass
Currently,
Muskulatur in den Beinen hauptsächlich
the
fehlt.
muscles in the legs fail him. What do you think are the chances that with therapies they can be built up over time? You said there are many that are still mobile and can walk.
Der ist jetzt 3,5.
How old is your son? He's 3.5. Well, I have seen positive developments at that age. However, this is different from case to case. For example, the MRI pictures can be very informative. If, for example, for your son, there's a lot of healthy muscles present in his legs, then this would be a positive sign. That would be a very important aspect to help diagnosis. But I did have patients with central core disease who still make positive developments at age 3 or 4. Often a dislocation of the hip is an issue, so that could make it more complicated. Well, he did have surgery at age 6 months. Well, we also tried to work very well on the hip and to solve any issues as early as possible. Heinz, I have a quick question. At the mutations in the RYR1, is there genotype-phenotype correlation? Can you say that because of this or that mutation, there is a different type of development of the disease? Well, I think that there are different group associations. It is not the case that, well, apart from the central core disease, but in other recessive mutations, it appears to me that most of them have a truncating mutation that lead to a major reduction of functioning protein exchange. I think that most patients have issues with the eye muscles. I think that there are other recessive mutations. For example, there were some children who had the King-Denro phenotype. That was a mutation of malign hypothermia. But the genotype-phenotype correlation is not completely on the level of one single mutation, but is on the basis of several mutations and on the consequences on protein level.